Professor Dr. Emre Merdan will talk about radiation therapy with SRS and IMRT for the prostate brachytherapy. Professor, the floor is yours. Please, your experience and knowledge with us. And after the presentation, we will going to have some question for you from the audience. Thank you.
So, thank you. Welcome to everyone. Today, I want to talk about some modern radiotherapy techniques. So, before starting, I am also affiliated with Istinye University Hospital. So, we may have some guests on the Istinye University also after working, of course. So we have basically three devices. One is Versa HD radiosurgery device. Second is Flexitron system, and the third is very soon Unity 1.5 Tesla MR Linac, which will be the first in Istanbul. In this year, we will want to start with MR Linac also. So, you know, the image guidance is very important for all radiotherapy concepts. Whatever you want to do is, which is mostly stereotactic radiotherapy and intensity modulated radiotherapy, which is the basic standards of all our countries' standard is intensity modulated radiation. And of course, 4D prostate brachy and also 3D interstitial GYN brachytherapy, whatever you did, you need some kind of image guidance. So if you look at what kind of image guidance we may use is, one is computed tomography, very commonly used methodologies, computed tomography. Of course, this is both CT treatment planning and COMBIM CT during patient on the treatment table. So we can do stereotactic radiotherapy to the brain and to the body areas. We can do, again, IMRT with CT guidance, and also we can do 3D GYN interstitial brachytherapy with hybrid applicators, again, CT guidance. Ultrasound also is being used for as a guidance methodology. So we have real-time transrectal ultrasound guided transperineal HDR brachytherapy option. Also, this is the only center in Turkey is our center, and very soon in Istanbul, MR guidance will be started during treatment. So this is very important issue, especially when you are treating the targets at the abdomen. Especially, it is hard to see. Again, MR-guided radiotherapy helping us to understand how the tumor response is going. We call it during radiation diffusion-weighted images can say some information about how the tumor is answering or responding to radiotherapy, which is also very good beyond the seeing during radiation. It's also say something about how the tumor is responding our radiation. It's a future technology. So if we look at image guidance, of course, daily image guidance is very important because, as you see for left side of the panel, as you see, the rectum is empty. And let's say that specific day, right side in the treatment machine, we did COMBIM CT, and what we see is rectum is full of gas and stool. So if we give radiation in this kind of case, this is, as you see, again, you can treat prostate accordingly, but the problem is unnecessary rectum is going inside your high dose area. So this is why 3D daily image guidance is very important. Again, even for palliative cases, this is our daily standard to look at the daily image guidance for every case. So of course, intensity modulated radiation is helping us to have better target coverage, better normal tissue sparing, and most of time it's help us on lesser toxicity in comparison with 3D conformal radiation. So, you know, we have the Versa HD radiosurgery device. This device has a very specific 1.160 leaves inside of the head. This head is helping us to give the radiation or the concentrate the radiation where we want to irradiate, and after radiation happen, dose is rapidly falling off, rapidly decreasing. For right side the video, right lower video, you can see that. So this first area is the high dose radiation area, and the second dose is 1/3. So within 7 millimeter, we can decrease the dose even 1/3. So it is very good dose decrease, can help us, but also warn us about something that is image guidance again, because this is kind of double-edged sword. Because if you have very good device to decrease the dose effectively, and you have to be careful about you are treating the correct area. So this is why again daily image guidance is very important to be sure of you are treating the correct area. So at that case, we already talked about, so this is a renal cell cancer. Left kidney has removed because of cancer, but we have some metastasis both around the medulla spinalis area. You can see the red circle and some blue circles showing that very near the kidney there are some metastatic nodules, and we give, this is, you will see this video, this high dose, I mean treating those
post-rehabilitation for the foreman who is not luckiest one. Orthopedic rehabilitation, translucent injuries, or some and hip bone replacement, or
okay. As you see, this is the lower doses, and the after radiation, you can see in the PET CT complete response and whole tumors is gone, and this is an effective irradiation, and the kidney functions are perfect. This is the only kidney the patient has. So again, with image-guided radiotherapy, we can do stereotactic body radiotherapy for some metastatic areas in the body, also IMRT for, again, metastatic or primary tumors. And also we can use image-guided radiotherapy for brain metastatic directed stereotactic radiosurgery, all again with image-guided radiation. So this is the case with colon cancer. Previously, yttrium to the liver caused complete response in the liver, but still we have some 2 metastases in the lung. As you see, this is left side, you will see the half dose. Right side, you are seeing the full dose. As you see, the heart and the normal lung tissue is effectively spared by radiation, and this kind of metastatic cases is just now treated as a curative intent. So when we look at our last 6 months Versa HDRS device image-guided SBRT numbers, so we have 45 lung metastatic cases with 121 metastatic lesions, which means that almost 3 metastases per case together we are treating together. For the liver, again, we have 16 patients, but the number of total lesion is 31 because of some cases have multiple metastases. So when we look at lung stereotactic body radiotherapy system, we mostly want to try to stop the or try to decrease the abdominal or diaphragm movements for upper abdomen and also lung cases. So this is in an easier way reproducible, causing smaller ITV and PTVs. And after having the pressure is just touching the patient's abdomen and causing the more more slower respiration, cause less movement. So why this is important? So this is the same case but different metastases in the different times. So for the left side of the video, you can see that the tumor is even small, it's moving because of the respiration. As you see, the diaphragm is effectively is moving because of the free respiration. So same case, we did second time new metastasis come, and we did another stereotactic radiosurgery with abdominal pressure. As you see, the diaphragm is not moving too much, and it cause also tumor is not moving too much, and helping us to treat smaller area and lesser toxicity. So this is the metastatic case near the heart. This is also, you know, hard to treat. Sometimes we are afraid into giving some toxicity, but as you see, again, with abdominal pressure, these are 4D images, 4D treatment planning CT images. As you see, the tumor is moving, but inside of our planning target volume, so not going outside. And as you see, diaphragm is not moving too much. It is just very slowly moving and helping us to treat smaller area, which is very difficult area to treat near heart region. For this case, this is the dose distribution. For upper panel, this is full dose. The lower panel, the half of the doses. And as you see, the heart is paired effectively, again, with abdominal pressure and small amount of diaphragm movements. So, of course, whatever you plan, we don't know if you can give this radiation correctly in the treatment machine. So again, in the treatment machine, having to have 4D Combeam CT in our system called symmetry system, this is a very slow computed tomography of the lung. As you see, the tumor still inside of our treatment volume. So it is good to see because this is heart area to treat, near heart, some risks, so you don't want to irradiate the wrong places. Seeing this 4D Combeam CT is very helping. It's very helpful for us to sure about if the radiation is correct. After seeing that, we just give our radiation. So with this abdominal pressure system, so this is an interesting case with nasopharyngeal cancer, adenoid cystic carcinoma. Post-op, the operation was done anyway. Nasopharynx is difficult area to operate, but some doctor operated, and then we did radiotherapy to the local area. The local area is clear, but as you know, the adenoid cystic carcinomas tend to go to the lung, and these are maybe 12 or more metastases in the lung. One of them is, you can see the left upper panel. This is after radiation. As you see, the tumor has gone. Well, this is, of course, the multiple metastatic nodules are there. We give radiation. So the patient's all metastasis has gone. Only thing we see is in the still early period. After 6 months, there are some radiation-induced changes, but will recover with time. So this is effectively treated nasopharyngeal adenoid cystic carcinoma metastasis to lung. All nodules is just smaller now. So again, this is a difficult metastasis from renal cell cancer, stable under systemic treatment of 1 year. So this is even hard to see metastasis. You can see in the left side. So we talk with our surgeons. Surgeons say that it is even hard to find area. We may not find this nodule effectively. This is a difficult place to irradiate. And we decided to do radiosurgery, and then you can see the half dose and full doses distribution. You can see the tomography and the movement of the nodule. And 2 months later, the nodule effectively regressed and still under control. And in this way, we can have good response in this case. So also sometimes liver, Dr. Emre talked about liver-directed treatments, but sometimes the liver metastasis can also be effectively targeted by radiotherapy. Also, again, stereotactic by the radiotherapy is very helpful for treating these kind of areas. So as you see, again, for the COMBIM CT, the diaphragm movement is effectively depressed, so it is helpful to see. Of course, it is better to have MR-Linac, which we can see the tumor during radiation, also the soft tissue tumors. It will be very easy to see. We will happily and soon we can use MR-Linac, but for now, again, depressing the respiratory movement, we can treat radiosurgery, we can do stereotactic radiotherapy to the liver metastatic area. So you can, another case, this is 4 metastases from colon cancer, not suited for surgery. We did radiosurgery for this metastatic focus. You can see MR-related changes in 3 months later, and the PET CT is completely disease-free 6 months later. So for adrenal metastasis also, it is not easy to see. We know this issue very well because this area, it is the CT treatment machine CTs is not so perfect, but anyway, good to see, at least to see vertebrae and also kidney, and we give our radiation with this again abdominal pressure system. It is, of course, after that we will use MR-Linac for these kind of cases. Again, some centers is using ABC device for radiosurgery purposes. We have this device. We mostly not use for radiosurgery, but effectively we can use it for left breast cancer in order to remove heart from the thoracic wall. So this is a air breathing control device, always sending same amount of air inside of the lung. In this way, it is conveniently you are treating the correct positioning of the patient. We talk about many cases for oligometastatic cases. We are very aware that different kind of metastatic cases come to us. Sometimes it is synchronous oligometastasis, sometimes it is metachronous, sometimes at the beginning polymetastatic, but very good with systemic treatments, it become oligorecurrent metastasis happen, and then we give oligorecurrence directed stereotactic radiotherapy. Of course, so it's a very good technology to have, but how can we use, and we always thinking that many people in the world give some kind, get some kind of immunotherapies also. Immunotherapy is the effective way of treating, many metastatic cases. And the question is coming to us, if patient has more than one metastasis, should I only one metastasis do radiosurgery, or multiple metastases should be irradiated? So there is a study showing us that if you target multiple lesions with SBRT, it's working more effectively with immunotherapy than only single lesion targeted stereotactic radiotherapy. So again, you may remember the oligometastatic, the definition is up to 5, but the new coming Comet 10 trial including the patients between 4 to 10 oligometastatic tumors, which is very important area for radiation oncology to give some good radiation. Of course, we are using image-guided radiotherapy to do brain SRS also, brain radiosurgery. So in our brain radiosurgery system, we have 6 degree of freedom table couch. So with this table, you can compensate even very small rotational errors, which is very good to have in this way. This is conveniently treated effectively. So this is a trigeminal meningioma with if you look at our brain metastatic cases, since only last our 8 months, before we have truly mistakes, but we just change our device to Versa HDRS, and this is for 6 months we treated almost 40 brain metastases, and each case we have almost 6 metastases, and we try to respect those constraints. We give 27 grain 3 fraction if there is no organ at risk problem. So this is the 14 metastatic case. As you see, the full dose and half dose, the metastases are effectively gone after radiosurgery. So this is the Yamamoto paper, very, very important, saying that if the even patients 2 to 4 tumors versus 5 to 10 metastases, there is no survival difference. So this is why we try to again do radiosurgery, but not whole brain radiation in all in all proper cases. We try to not use whole brain radiation. So this is a new paper coming and say to us what kind of those constraints, because previously we don't have this kind of those constraints, but when we have multiple lesion metastasis, so we need this kind of those constraints, and this will be very helpful. So still some people may have some question about if we have to send any metastatic case to the gamma knife versus LINAC-based radiosurgery. So there is no, it is again a new study showing that there is no survival difference between gamma knife versus LINAC, especially for 2 and more metastases. And but the basic difference is between gamma knife radiosurgery and LINAC-based radiosurgery is the number of radionecrosis is more radionecrosis we are seeing with gamma knife system. So this is also we sometimes see radionecrosis. This radionecrosis is effectively treated with bevacizumab after radiosurgery. So this is one of radiosurgery case come to us with continuous seizures attacks after radiation. Seizures has stopped and the metastatic focus is smaller. So this is a skin cancer case we treated with stereotactic radiotherapy, because before us the patient is offered to do surgery for all eye socket will go. We just do radiation, and 2.5 years later our radiation patients passed away because of heart issue, and the eye is completely working. So another concept I want to talk about you is for the transrectal ultrasound guided real-time prostate HDR brachytherapy. So this is also important issue because you can decrease the total radiotherapy time of prostate cancer, and also you can increase the efficacy. We are the only center doing HDR prostate brachytherapy in Turkey. So of course, every patient is not okay with this technology for smaller prostate, relatively also no obstructive cases. There are some contraindications. We have to be careful about that. Otherwise, we can do HDR brachytherapy for if the patient has low risk prostate cancer, then we can give in 1 week radiation, so give radiation. This is 4 hours procedure, and then patient next day go home, and again 1 week later come again, we give another radiation, and the patient can go their country. So for low risk patients, so it's very 1 week treatment very effectively. Also, if the patient has high risk or very high risk features, then we can give boost brachytherapy to the prostate. This is only one fraction. Again, 1 week later after this fraction, we will start external IMRT. So this is also another the brachytherapy area we can give. So right upper panel, we can also do liver brachytherapy. Sometimes it could be necessary. Also, intraoperative interstitial brachytherapy sometimes is necessary, especially for relapsed cases. When the surgeon remove the tumors, we can send our plastic tubes to the operating bed, and then we can give radiation. This is the again the hybrid applicators are also very important. So these are the normal classic gynecologic applicators with some interstitial tubes. So with these tubes, we can give better dose to high-risk CTV in cervix cancer patients, and also sometimes inadequate implant anatomy matching issues can be dealt with these kind of needle insertions. Also, we can capable to have this. So this is a skin cancer brachytherapy cases. You can see this is an interesting case, 91 years old guy. So this is after external beam radiation with electrons. There is no complete response. We give brachytherapy and the tumor has healed, and it's very good for them. Again, for brachy issue, we are accepting some visitors on the Brachy Academy platform. You can just apply them if you want to visit us. So also we have sometimes have international RTT fellows, also radiation oncologists sometimes come and visit us. This is just we need some arrangements. After arranging everything, we can accept the people. This is my part of my team. This is my a little bit background, and this is where our hospital is just near Bosphorus area. So this is my last slide. I am happy to answer.
Hello, Professor. Do you hear us?
Yes, yes, sure.
You can stop the sharing if you finish your presentation.
Yes, I'll stop.
We have two questions, actually. SRS can be used on the metastasis in Pons area.
Yes, sure. So basically, you can use it for also bone area, but so IMRT may be better way for myself, but especially I am try to use, especially for rare radiation, if I want to spare the medulla spinalis, and this is a rare radiation, because it is hard to find metastasis in the bone. I mean, generally, bone diseases is mostly more disseminated ones. I prefer to use whole bones mostly, but if the you are sure that metastasis is very small area, you can easily use radiosurgery for those areas, but try to give lesser dose than the.
Thank you for second questions coming from eye surgeon and eye doctors, saying that if SRS technique and technology can be used for tumors of retina and in generally for eyes tumors.
Yes, we are using it. So of course, we are collaborating with some, iodine implants for the brachytherapy issue. So we have a collaboration with another team. But if the patient is not okay with local brachytherapy, of course, we can do radiosurgery. I have some cases also for retinal area, but we prefer to do some volunteer eye immobilization, but for the patient cannot do some volunteer immobilization of eye, because small movements can change big differences. So we can use sometimes eye blocks kind of things. In this way, eye is not moving so much, and we can do this kind of under local anesthesia kind of eye immobilizer, and we can do radiosurgery. And I have some cases with voluntary immobilizing of eye, and also radiosurgery is working in the cases if the case is not okay with local brachytherapy issues.
Thank you very much, Professor Merdan, for your comprehensive presentation and very high technique. We have talked about radio oncology and brachytherapy. Thank you for sharing with us.
Thank you. It's my pleasure.
Hope to see you in our next events as well, to share your knowledge and experience with our other countries' professor and doctors. Thank you.
Sure. I will be happy. Thank you. Thank you.
Thank you very much. Ladies and gentlemen, short video about Physiomer, our next presenter. After the watching the Physiomer movie and videos, then we will be together with Dr. Melih Ünver.